young population, at some point they are going to expose the older vulnerable people and the other vulnerable people in the population, so that hospitalization and that uh, number of deaths is probably going to lag, but only time will tell. So this is another representation of which countries, which nations in the world were contributing to the number of deaths over this time period. So as you can see here, a great proportion of deaths were in the United States. Yes, that has decreased. South America has seen a surge in cases and also a surge in number of deaths. And we'll just kind of leave this graph here for a little bit, so you can kind of, take that information in. Okay. I also wanted to kind of let you know, if you want to interrupt, have any questions, please feel free to either raise your hand or send a message to Dr. Alsamari, and he can kind of flag me up or stop me. So just wanted to focus on our state and where we stand in comparison to some of the neighboring states. This graph only allows me to pick 6 states, so I just picked top few, and then Kansas City because we are close to there. So this is again on a log scale and cumulative cases so far to date. So that's 22,830 cases in Missouri, and that's where this line has dropped here. And for new confirmed cases for these same number of states, you can see how we kind of have trottled along, and we are kind of seeing spikes. As of July 2nd, there were 400 new cases in Missouri. You can see how this blue line is Texas, green is Florida, California, and Arizona, who have seen a real increase in number of cases here. Okay, and then the number of new deaths attributed to COVID-19 in these same states, again, we have seen about 5.1 average new deaths in Missouri as of July 2nd. Did you have any questions, Dr. Olson?
I do have, yeah. How can you explain this very steep decline in death in New York?
I think they were very, very good about all their mitigation strategies. And being closed down for such a long period of time. I don't know, do you know if when they reopened things out there? But I think it's mostly because of all the social distancing and mitigation that they took care of. And all of us in the other states had reopened. I think we reopened on May or first week of May.
First week of May, yeah.
Been a couple months, so that's what I attribute that to.
Why is Missouri that fluctuating up and down?
I don't know.
Okay.
Most of our cases are coming from St. Louis, and I have some Missouri data as well. They're from the big cities. I'll just show you that information shortly. So this this graph kind of shows us how the how much excess deaths have occurred in all of these countries that have faced the COVID-19 outbreak. So the black line is kind of an expected deaths that are seen, and then the red line indicates that many excess deaths that happen in that time period. So whereas United States is far down, so there were, of course, there were 122,000 excess deaths that could be attributed to COVID-19. And this is kind of the CDC puts out every, there's this constant surveillance happening for influenza-like illness. And all this information is really nicely curated on the CDC website. So if you can see in 2018, when that red line goes up, that means to say that the number of influenza-like, this is not cases, this is for deaths due to pneumonia, influenza, or COVID-19. So at that point, we know that all of that excess death was due to influenza in that season. So these week counts go by week number 1 is the first week of January, week number 52 is the last week in December. So as you can see, around this late December, early January, February period, the red line goes past the epidemic threshold, and then we see this amount of throughout the year there is some fluctuation, and then into 2020 we saw so many percentage of excess deaths, and these are attributable to pneumonia, influenza, or COVID-19, and we know that by that time influenza was gone, and so it's predominantly due to COVID-19. So, this is also from Financial Times, tells you how many people died in Missouri, 1,000 plus people from COVID-19 in comparison to so many other states. Bigger the circle, more number of cases. And then coming to what I was telling you earlier about how many new cases are happening each day. So we reached an all-time peak on July 1st and 2nd. Actually, on July 1st, this data from CDC suggests 54,000 new cases that were in that one day. So which states are seeing this increase? So this is also from the John Hopkins website, where it tells you the percentage of positive cases. So I know everyone, the argument is being made that we are testing a lot more, so we are capturing a lot more, but that's true. But we are also seeing an increase in number of positive cases. So it can't just be that we're testing more, and that's why. So actually, Missouri did go into the above 5% threshold. So this 5% threshold came from WHO, that for for benchmarks and everything, for community kind of for mitigation strategies, they recommended 5% of positivity as a threshold, and we went into that very recently. We went into that 5.14 right here. PR is Puerto Rico. I couldn't figure out why they reported 100% of cases, but I'm sure that is kind of some anomaly in this particular graph. But here we are with New York now. They're reporting only about 1% positivity. New Jersey only 1.5%. And we, all these 29 states are, at least 28, are way past that 5% threshold. This is from the so looking at age-wise data, so this is from CDC website. So public health, so these are state and local public health labs that report. So on the y-axis, you see number of specimens tested. On the x-axis, you see the number of positives. But I wanted to bring this up to show you a breakdown of age-based. So since we're going to talk about children, I wanted you to focus on this orange line here, which is for 0 to 4 years, and this gray line here, 5 to 17 years. So as you can see, yes, we are seeing more a rise in the number of percentage of percentage positive orange cases. That's on this y-axis. But also note that orange only contributes to a small number of tests contribute to only a small number of this whole graph, and the gray. So the number of children tested are probably, I would say this would be around 2% of persons of the whole population tested. And there is a similar information from commercial labs. So for example, labs such as what our immune health system has been using. We have mostly been using one of our commercial local laboratories for testing here. So again, they have also seen a similar trend. So the same color codes of orange and gray. Again, this information is really easily available on the CDC website as well. So again, to break down the number of lab-confirmed COVID-19 associated hospitalizations. So as you can see, orange 0 to 4 and 5 to 17 is a very, very small number of children being admitted to the hospital with COVID-19, as again, 65 plus year olds. Black is like the overall cumulative hospitalization. This is 50 to 64 year olds, and then the 18 to 49 year olds, whom we think of as relatively healthier adults than the other prior to age groups. So this is information also from the CDC website where, again, I wanted to show you the hospitalization rates. So as the same kind of data in a different format, this is number of persons admitted to the hospital per 100,000 population. So again, it's the highest in this age group. As you can see, it's way higher in 85 and up year olds, 75 to 85 4-year-olds follows that, and then followed by the 65 to 74-year-olds. And among the children, we know that the infant hospitalization rate is slightly higher than all the, so infants meaning up to 1 year of age. And that's why that probably contributes to slightly higher rate of hospitalization in young kids compared to those who are 4 to 17-year-olds. Although we know that the teenagers, the adolescent, late adolescent children seem to behave more like adults. Another thing too I wanted to bring to attention, I think you've all heard about how social disparity, social economic disparity contributes to hospitalization rates. And this is really eye-opening here, that shows that, rates of hospitalization in American Indians, and Alaskan Natives and in Black Americans is 4 to 5 is about 5 times that of white Americans, and this is closely followed by Hispanic or Latino Americans, whose hospitalization rates are 4 times higher than non-Hispanic white persons. So this is an MMWR. I'm just going to kind of bring your attention to just focus on the pediatric data. Again, this was released on June 15th with the publication date of June 19th. So this captures CDC surveillance data from January to May. And I would mostly just focus on this percentages here. So in the 0 to 9-year-olds, we know that only the number of cases contributed by 0 to 9-year-olds was 1.5% of all the cases, and for 10 to 19-year-olds was 3.7% of all the cases. And then again, I've highlighted these numbers. So this data is also from the CDC. I wanted the rest of this, even though it's a busy slide, wanted you to have this information so that if you wanted to look back, you know where to look for. And so let's break it down a little bit. So this is the outcome of those confirmed with COVID-19. So of all those 0 to 9-year-olds, 4% of those diagnosed with COVID-19 were actually admitted to the hospital, and 2.5% of those diagnosed with COVID-19 were admitted to the hospital. Now these two red circles that follow through are of those admitted, like how many had underlying health conditions. So in that 0 to 9-year-old age group, 22.3% of those with COVID-19 had an underlying health condition, and 15% of 10 to 19-year-olds. Now the ICU admission rates are much smaller. So again, that is also should be reassuring to us that 0.7% of all children in that 0 to 9 years were actually admitted to the ICU, and only 0.4 of all were admitted to the ICU. And I have to say that there were unfortunately 46 deaths from this entire cohort, 46 pediatric deaths, 13 in under 9-year-olds and 33 in 10 to 19-year-olds. But again, that number was slightly higher, meaning that if you have an underlying condition, then you're relatively more vulnerable to being hospitalized, to being in the ICU.
Can I add something here, Dr. Padier, just to translate these numbers into practical example? Can you go back to the slide, please?
Yes.
Can you go back to the slide? I think so. Yeah, here. So, no, with the busy one with this lot of circles. The one after this. Yep, here we go. Yeah, so
sorry, it's delaying a little bit then.
Oh yeah, no problem. So this means children under 9 years old are have like risk of hospitalization of 22.3%, right?
I wouldn't say the risk of hospitalization, that is, I wouldn't call it that they are at increase, like the risk is 22%. It's the
Of
all
severe
the
infection.
reported hospitalizations 20 in that age group. So
Uh-huh.
um
So if your kid is healthy
yes,
without underlying conditions
yes,
and they get infected, let's say roughly there's about 22% chance that they may need to be admitted. With a mortality rate less than 0.6%,
yes, yes,
0.6%.
yes, yes. So definitely having an underlying health condition puts you at an increased risk for being hospitalized and for being in the ICU.
Will you define this underlying conditions for kids?
Yes,
What
I
do
will.
you mean?
I will. I
Thank
will
you.
shortly do that.
Great.
So as you can see, fever, cough, and shortness of breath are the predominant symptom across all the age groups. So this is kind of all the kids, again the same number as before. 14% of the kids had underlying health condition in less than 9-year-olds, and 10 to 19-year-olds as well. I'll come back to the high risk factors shortly. This was again to kind of reflect how much, if what is the proportion of hospitalized cases in all of these different, um, you know, um, underrepresented minorities, people who are vulnerable. The rate of hospitalization was, again, as I mentioned before, highest in Native Americans, followed by Black Americans, followed by Hispanic, Latino. And the proportion here, just prevalence ratio, means that it's number of cases over the proportion of people who actually are in that population. And that's a little bit more reflected in a little, maybe I didn't capture that data. But anyways, so the same MMWR, so all that data that I quoted was from this MMWR, which stated that hospitalizations were 6 times higher and deaths were 12 times higher for those with underlying conditions. So for adults, most frequently reported underlying condition was cardiovascular disease, diabetes, and chronic lung disease. Here is the information on the underlying conditions that that I alluded to earlier. So if we just focus on the steel-colored graphs, asthma, obesity, and neurological condition. These were the main 3 underlying conditions that were most likely to cause hospitalization in children. Now, granted that this data is only from about 180 hospitalized children, but half of them at least had one underlying medical condition. And along those lines, same thing for adults as well. The most commonly reported underlying conditions were hypertension in 54%, obesity in 49%, chronic metabolic disease, and cardiovascular disease following that. So what have we seen in Missouri? We have seen 22,830 so far lab confirmed cases, and an increase in 1.3% change in statewide cases in the last 24 hours, and 8.2% change in statewide cases in the last 7 days. Boone County has had so far 395 cases. This is the breakdown of cases by age in Missouri. So as you can see, 0 to 19-year-olds, so they don't break this down any further. So that contributes to 7.6% of all the cases. Certainly, again, even though this is 7.6% of this whole population, the number of the hospitalization rates are much lower. So in Boone County, what we have seen is, according to this graphs, there have been total of 460 cases just in Boone County, and 2 patients were deceased. This is more concerning to me, is that in the last couple days, we have seen the highest daily positive. Another resource tells me this number is 39, but close enough. Still the highest number of cases, new cases reported on one day, just in our county. This was the data I was referring to earlier. So in our county, even though African Americans contribute to only 8.8% of the total population, we have seen that they are more at risk for for getting this infection, and in comparison to the other races. So these are the Boone County positive cases broken down by age. There are about 39 cases reported in children. Now, I have to say that, yes, we have, the hospitalization, at least we've had a couple cases who have been admitted, but neither of those children have been from our county. They're from a referral area. So I can at least tell you, from as far as I know, to our hospital, we have not had any of these positive cases, and that should be reassuring to us. So I think we all know about these tests that are available. The test that we commonly refer to is this PCR test, which is a viral test. The PCR looks for the DNA of the virus, and there are some antigen tests, but these we have not been, at least as far as I know, in our hospitals, MU hospital system, we haven't started to use the antigen test. So the PCR test is fairly, yes, it depends on how good the operator collects the test and runs it and everything. But so far, we know that if the test is done appropriately, the sensitivity, the test performance is very good, both sensitivity and specificity of that test. Now, the serology test has brought up a lot of people have been very anxious for this, thinking initially we thought that maybe it's going to tell us if we are immune to it, but I think over time we have realized that it probably does not reflect. Yes, it will tell you that at some point you did have the virus, because it detects the proteins that your body produces in response to the viral infection, whether you're symptomatic or asymptomatic. But we don't know how effective these antibodies are in preventing you from getting an infection again. And also, it doesn't tell you if you have active infection or not. Actually, I was very I only came upon this yesterday when I was looking for this, and I hadn't realized that this data has been out there for at least a couple of weeks now. So based on some population specimens, some pooled specimens from labs when they did antibody testing for Missouri, so that's this 2.65, this number here, what they found in that seroprevalence, meaning when they did the serology testing in retrospect for a certain period of time. Let me first point out to you for Washington State. So the prevalence estimate they got was 1.13. So that was in that early time period, March 23rd to April 1st. At that time, 4,300 cases were reported from that area. But based on a seroprevalence of 1.13, there should have been so many cases, 48,000 cases. So there was that discrepancy between the number of reported cases and the number that were estimated based on the seroprevalence study. I'm sure there may be some flaws, and this difference may not be this high, but I think it's something to remind us that yes, people can get asymptomatic infection, and maybe we are missing those, or mildly symptomatic and missing those. So for New York region, when they used bank samples from that period, at that point in time, there were 53,000 cases reported, but based on a 6.93% seroprevalence, that estimate was going to be 12 times higher than what was actually reported. And for Missouri, from samples that were collected between April 20 and 26, 2.65% were positive for antibodies. And by that time, only 6,800 cases were reported, but the estimated cases based on the seroprevalence should have been higher. So I think I would not read too much into this data, but just kind of take away that people can probably have asymptomatic, mildly symptomatic infections that were not recognized. Again, it heavily weighs in on why people should be socially distancing, why they should be masking. So just to do a quick brief on COVID-19 and how it affects you. So we predominantly think about it as a respiratory virus, although there are many other organ systems that are involved. So in a healthy lung, you can see how the main windpipe, that's the trachea, branches like a tree into smaller branches. And at the most smallest branch of these are these air sacs where actual oxygen exchange takes place. And these are lined by two types of cells. One is called a type 1 cell, and the other kind, and that's kind of and the other type of cell is called the type 2 cell. So the type 1 cells are thin enough to allow oxygen from the air to kind of pass through into the blood capillaries so that it can be carried on to the rest of the body eventually. And the type 2 cells are the ones that produce this surfactant. It kind of is like this lining that keeps this alveolus kind of open and keeps it from collapsing. So when this SARS-CoV-2 virus, the virus that causes COVID-19, has this spike protein, these projections that bind to some receptors. So they dock into these type 2 cells, and they kind of incite an inflammatory response. The body is trying to fight off this virus, and in the process of fighting the virus, it produces a lot of chemicals, inflammatory signals, which, while trying to fight the virus, will also kind of cause damage to that area as well. So while this whole process is going on, air does not exchange, and then you have pneumonia and then the subsequent kind of respiratory distress syndrome, which happens in the most severely sick people. So what other organ systems are involved? You have all heard about how the heart and blood vessels can be affected, because they also have the same ACE2 receptor, which can where the virus can dock into. And so the infection can promote blood clots, heart attacks, inflammation in the heart. People have reported strokes, neurological symptoms reported are strokes, seizures, confusion. I don't think we know exactly how the neurological effects happen. There can be inflammation in the eyes. And then, of course, you've all heard about how people lose their sense of smell. Although this happens also in other respiratory viruses, it has been pretty significant a symptom even in COVID-19 patients. In that one graph where I showed you before, sorry to take you back some, loss of smell or taste was reported in total, in about 8% of people, and diarrhea in about 20% all comers. So there are also gastrointestinal symptoms as well. The liver can be affected, kidney damage can occur, and we just talked about the intestinal symptoms. We know this virus can also be shed in the stool. So in summary, symptoms of this viral infection include, cough, fever, need not be present in all patients, roughly in about 40 to, so less than 40 to 50%. So less than half the number of patients will have fever. So shortness of breath, difficulty breathing, this fatigue and myalgia, sore throat, loss of taste or smell, and in addition, things that I mentioned a little bit earlier, nausea, vomiting, diarrhea. But we want you to kind of seek attention if you have trouble breathing. Those are really warning signs. Trouble breathing, chest pain or pressure in the chest, new confusion, not being able to stay awake, or being excessively sleepy, and change in color of the lips. So what diagnostic tests and at what time frame? So we know that people can be infectious. At least the current timeline that we think about is an incubation period of anywhere from really a short period of from 2 days, as short as 2 days, all the way to 14 days, which is very different from influenza, which has a very short incubation period. And also the other worrisome thing is that you can in that couple days before before you start having symptoms, you can start to shed the virus in relatively high numbers as when you start becoming symptomatic. So that's why this this push towards using a mask, because you don't know that 2 days from now you're going to have symptoms. So you want to protect yourself and protect everybody else around you. You want to protect everyone else around you. So one of the things, just to remind everyone also, is that if someone was diagnosed with COVID-19, the health department will do contact tracing, and they'll kind of give you directions on when you can come out of isolation. The current understanding, now this data is changing, because at one point it was usually everyone's going by the symptom-based strategy for relatively healthy people. But in this symptom-based strategy, you would need to be, from the onset of symptoms, you would need to be in isolation for at least 10 days, and your symptoms should have been improving for at least 3 days in a row, and that's when you can come out of isolation. So one of the things is that those who may be vulnerable, so we know that some people can be shedding the virus for a long period of time, and so in those people, it would make sense to wait for the test and have a negative test before they can return to work. Although all of these recommendations for healthcare providers, even for this coming out of isolation, at one point it was at least 7 days had passed, but as new information came about, they found that even though the virus was shedding for a long period of time, it was not viable for culture. So it was not effective in passing on the infection after 10 days, of first detection. So that's why that number moved from 7 to 10 days. So I think we just have to keep waiting to find out what we learn about this infection, and be flexible to accept that as information changes, we should also change. So again, kind of just wanted to remind everyone about, why social distancing is important. Although we say, like, yes, 6 feet is the best distance, there is some data to suggest that any distance is good. So 3 feet, yes, 6 feet would be great, but even if you can maintain 3 feet, but that 3 feet kind of applies to some of the school recommendations that we will talk about. But yes, when we talk about social distancing in the community, staying 6 feet away, using masks, and when you use masks, try not to touch your eyes, nose, and mouth, because then you're contaminating your hands, and you can move past things over. So yes, there was that data about how the virus can live in the environment for a few days, but we don't think that as being the main route of transmission. The main route is predominantly being passed from sick people by respiratory droplets. So who are the people at increased risk? So at any age, those with chronic kidney disease, lung disease, whose immune system is weakened, those who have a high body mass index of greater than 30, those with underlying heart conditions, sickle cell disease, and type 2 diabetes. Children specifically, again, when we talked earlier about was the asthma, underlying neurological disease, and obesity. But we know that children who have additional needs, who have complex medical needs, they are vulnerable to any viral infection. So we would consider them at increased risk for this as well. So this is a list of all the conditions where they might be at increased risk. So even though we don't have very sufficient evidence to prove they are definitely at, I would still be careful for this group of population. So as you can see, asthma, people who have history of strokes, cystic fibrosis, high blood pressure, pregnancy, those who are smokers, those with type 1 diabetes. So what are we doing in the hospital? As just wanted to kind of go over this very briefly. When patients come to the hospital, or if there are patients under investigation, providers are wearing masks. Recently, it's been over a month since we moved over to universal masking for everybody in the hospital system, at least. And then if someone is under investigation for COVID-19, wearing gowns, gloves, eye goggles, face shields, because that is also not wearing those and being exposed to virus can also put you at risk of exposure. For procedures like needing nebulizers, if we have to give a nebulizer to a patient, then we wear the N95 type respirators. patients who are positive are admitted to dedicated areas for care of these patients, or in dedicated areas in the ICU. And management is predominantly supportive depending on the severity of illness. So it can be as little as just needing oxygen, or for severely ill needing ventilator, fluids, and in some really severely sick persons needing to be put on bypass, although those numbers are small. And then the antivirals. So you've heard a lot of debate about which medication, but so far, we have only had one drug so far that has proven itself to be superior in shortening the length of time to recovery in adults. So if an adult needing oxygen or needing to be on a ventilator was admitted to the hospital, then it would decrease the hospitalization time from 15 days to 11 days. And then more recently, there was information on steroids from this large study that came from the United Kingdom, where dexamethasone, so it's a type of steroid that decreased mortality in those who were really sick enough needing mechanical ventilation. So the other treatments, people have, there are trials ongoing for convalescent plasma and a number of other drugs. But I just wanted to highlight the main couple things that we are using in practice. So shifting gears to what have we seen in children, what was unique about children was this new multi-system inflammatory syndrome. So Italy saw back then in April, when a few weeks after the peak of Italy's cases, they saw more number, I think it was up to 10 cases or so of what they thought was Kawasaki disease. So Kawasaki disease, just to give you a general idea, it is an inflammatory condition that we see in young kids, typically less than 5-6 year olds, who may present with fevers past 5 days. So if parents who remember their children having fevers, usually the pediatricians are very tuned into doing the workup for Kawasaki disease. If a child has a fever without any other known infection or disease, when that fever goes on for 5 days or more, and if they have any other symptoms, so that could include changes in the eyes, changes in the mouth, hands and feet appearing swollen, an unusual kind of rash, some swollen lymph nodes on one side of the neck more than the other side. So those are triggers for us to evaluate for this condition. This is something, Kawasaki is something that we see throughout the year in very small numbers. So I think the numbers that I recall were 25 per 100,000 children in the United States is the incidence. And here we see a very small number of them, a handful of them every year. But suddenly in Italy, they saw more than the usual number of Kawasaki type presentations, followed by in the UK, where they saw a similar thing happening. They had reported 8 of those cases. What was unique with these were a little bit older children than what we see in Kawasaki disease. 3/4 of them, of the 8 cases that were published at that time, were of Afro-Caribbean descent. And all of these patients either had, they had an antibody test positive for SARS or a PCR. I don't remember the exact numbers there. But subsequently, there were more cases reported from there, and that led the UK Royal College of Pediatrics and Childhood to put out this alert for people to be on the lookout. And then soon after that, a few weeks after New York and the New York City and state had seen their peak, they started receiving reports of children with a similar presentation. And when they looked back, they saw that from mid-April to early May, they had about 15 children. And as of May 12, there were 102 children, including New York City. And so that's when the CDC put out their alert. So essentially, we think of this as a post-infectious inflammatory process. So not that they have COVID-19 at that time. At some point, they may have had COVID-19. But many of these cases, they don't remember, parents don't remember them being sick, although they do remember there is either, if they haven't had a positive antibody test or a PCR test, they've at least had a definite exposure. And so on May 14th, the CDC put out this alert and kind of gave us doctors kind of a case definition of whom we should be thinking, in whom should we be thinking about this condition. So so definitely it's, the case definition includes a child so less than 21 years of age with fever. All these children present with fevers. You will not miss that. And lab evidence of inflammation. So there are certain labs that can be done to look for inflammation. So they're all listed here that we usually would look for. And then having some kind of organ involvement, at least more than one. So two or more. So either involving the respiratory, cardiac, renal, blood, GI. So the same organ systems that COVID-19 we know involves. And there should be no other diagnosis here. And then the testing, they should either have a PCR, but most of these cases end up having a positive antibody test. That's the serology. And or if none of these, then at least they should have been exposed to a contact. So this just came out in the last few days, a very nice infographic from the CDC. So this was all the information that was reported from providers who were taking care of these children. As you can see in Missouri, in this green color, there were 1 to 6 number of cases that were reported. In total across the country, there were only 186. So yes, this is seems very scary, but it is very rare in comparison to the number of actual cases of COVID-19 in children. And as you can see from this graph, this peak up here is where we had seen across the country the percentage positive cases were the highest, and then we saw that drop in the peak, and that was followed suit in a few weeks later by the increase in number of these cases reported. From one of the recent webinars from one of the New York hospitals that I attended, they said they are hardly seeing any patients now, and that kind of makes sense because they are kind of they have seen a drop in number of cases in New York and in New Jersey area. So Kawasaki disease typically, like I told you earlier, affects mostly the younger kids, but this was unique in that it affects a fourth of these children were either in that 5 to 9 year age group or 10 to 14 year age group. So 8.9 was the median age group for all of this, for these cases. Now, again, the people who are affected are more number of Hispanic or Latino patients, more number of Black children, followed then by white and other non-Hispanic, and granted there were 22% where we didn't know. So these cases were the ones who met all of these criteria that I mentioned to you before. This is another infographic from there, just showing that in 18% of the cases, there was some kind of cardiovascular intervention. So they had different kind of tests and everything to find out if their heart was affected in any way, and the impact on other organs. Again, GI symptoms. So diarrhea was a predominant feature, some changes in the blood parameters, skin findings, respiratory system findings, etc. There are some treatment strategies. We have been treating these, patients just like we would treat Kawasaki disease with IVIG, which is like a blood product of antibodies pooled, not COVID-specific antibodies, just pooled antibodies from all it's a blood product that's available that's used for Kawasaki disease, and also using aspirin. Although some of these patients have required a second dose of IVIG, they've needed steroids as well, and some other immune modulating medications. From this graph, what I want you to take away is that the median, that most of these kids did well. They were only admitted for about 7 days in the hospital, although at that time, a fourth of them were still remained admitted, and a couple kids had died is what I was aware of, which is smaller than the 2% number, but I think this 2% data is not for all 2% of 186, but 2% of the outcome that was available at that time.
Buddy, can I just interrupt you for a second, please? Would you just mind skip the detailed medical information, try to get through the recommendations, for the sake of time?
Yes, we'll go there right now. We're done. Yep. So what has been the impact of COVID-19 on children? So, we know that so many new parents who need this social support, they've not had that because they can't engage their grandparents, they can't engage their other family friends in care of their children. That's the stress of the job, loss of childcare, and lack of, at one point when additional, like, children with special needs were not able to get their, physical therapy, let's say occupational therapy, all those therapies that they were usually in need of were not getting access to it because those services were closed. In addition to that, in adolescence, they were like, the problem of adolescents being socially isolated from everyone else and having decreased physical activity and exercise. So we know that children are at increased risk for physical or sexual abuse, substance use, anxiety, depression, and suicidal ideation just from being indoors and not having that social contact. I'll skip through a couple of these just to kind of point out that also we saw a dramatic decrease in number of vaccinations. So the point being that fewer number of vaccines were being delivered during this time period, 2.5 million fewer vaccines based on one of the databases. And so again, kind of emphasizing that we don't want these vaccine preventable infections to again resurface and cause problems, because we already have one big problem to deal with. So AAP, the American Academy of Pediatrics, provides this guidance for well care of children during COVID-19, which includes that now they are strongly advising that, yes, you can, even though you can get telehealth, this should be followed by a timely in-person visit. And also all the well child care should occur in person whenever possible. All children should get their well child checks get done and out of the way, get their vaccinations up to date. So the AAP also kind of put out their statement just on June 26th on what would they advise schools to do about reopening. So some of the facts that for the evidence as such, you can go to this link later on. This is a very nice curated literature on pediatrics, on children alone from one Dr. Munro from United Kingdom and his group of people. Very easy to read, but to summarize that why we think children are okay to go back to schools, because based on literature, we know that they're less likely to acquire COVID-19 than adults when they're exposed. That there is enough evidence that there are significantly fewer children infected in the community than children. Children are rarely the first case. Whenever there's a child, it's usually the infection comes from an adult to the child rather than the other way around. Now, we don't know how likely infected children can pass the infection to others. Can they pass it just as well as adults can? But there is no evidence to say that they are any more infectious. So the AAP recommends that schools be, that I think there is a question. I'm not keeping track of the chat. I'm sorry, I can't see the time either.
Past 11:30, and I'm tracking the questions as well, so you're
Okay.
good.
What time is it now?
11:35.
Okay, okay.
We should conclude
All
soon.
right. Yeah, well, another 10 minutes, we should be done. So some of the things that the AAP mentions is that schools, they play a very important role in not just teaching children, but also in social and emotional skills, in providing nutrition and safety for children, physical and mental therapy as well. So they also kind of fill in the gaps where there is social and racial inequity as well. By allowing these children to have a safe place to be at, by allowing children to have access to meals, food, and also allowing parents to be able to go and work. So we know that from the spring, what we have seen, that there have been negative impacts on learning, and so I was mentioning earlier about the 3 feet may be okay if the children are, particularly if they're wearing face coverings and if they are asymptomatic. Now, schools should weigh in their pros and cons of enforcing a 6 feet distance. That might be tricky to achieve. And pediatricians should be kind of tuned into families to allow for accommodating the unique needs of children. So some of the things that, there are a number of recommendations, and I'll make these slides available, but this is also available from the AAP Guidance website. I think I have the link down there.
Mhm.
Where, for pre-K kids, for example, they said focus more on mitigation strategies. So focus on hand hygiene, focus on adults physically distancing, focus on adults wearing face coverings and cohorting, and spending times in smaller groups indoors. Making use of outdoor spaces whenever possible, limit unnecessary visitors to school. With very young kids, it's very difficult to enforce masking because they're going to be touching their face and passing things on. I've even heard about in some camps where, this is anecdotal, someone mentioned how kids were like exchanging masks, which is a complete no-no. Somebody had mentioned that you need to tell your children to treat your mask like it's your underwear, not to be shared. Now, coming to elementary school, yes, they do recommend that if they can wear face coverings without increasing hand to mouth nose contact, then that would be something that you should prioritize. Place the desks maybe at least 3 to 6 feet apart if it's feasible, and minimize the amount of crossover that happens. For high schools, in addition to all of these, they also recommend having some kind of block schedules, eliminating lockers, utilizing outside spaces, and if possible, not having students move, but actually teachers move from classroom to classroom. And then throw in all of this mix. This is an old slide from before where, with coming of fall and winter time, we see respiratory viruses. So how are we going to differentiate typical common cold, so that's your rhinovirus, from something like RSV or influenza that will come in the winter time? And how are we going to differentiate that from COVID-19? It is going to be difficult. I know that the Missouri DESE is working with pediatric ID doctors to come up with some kind of guidance, but that's still not out there. People are still working on it. So I'm hopeful that by the time school comes about, there will be more rigorous or more clear ways of seeing who would be at risk, what symptoms, who should get tested, when can they come back, etc. Again, the AAP recommends that schools should have some mechanism in place for testing, for temperature checks. And again, as doctors, we should also be kind of be advocating for their child's needs and see if there can be any way to be flexible about the school's policies. So one thing I would recommend going to is this website called healthychildren.org. There is a lot of information for parents out there on how to navigate. And this is all based, this website is based off the American Academy of Pediatrics. So you'll find really very, hopefully helpful tips on a number of aspects, right from newborns to other things in, caring for children. And there's page 1 and page 2 of these. I would highly recommend kind of going through them and finding answers for your questions. I don't know if were you able to see the slide?
Yeah, so I think you need to change the share screen to share the the presentation.
Okay, hold on. Are you able to see this screen?
I see your presentation now.
Okay.
But not the link.
Okay, let me try to share this page now. So this is that healthy children. Sorry, I didn't realize earlier. Hopefully you can see this now. So there is a section on COVID-19 here and a number of page 1 and page 2 of all questions that parents are wondering or concerned or want answered. I think that's all I have for 1 second. I will go back to my slide set, and I should be almost done. Okay. You're able to see my screen now.
Yep.
Yeah. So again, a little bit on this wearing masks. I think this graphic from one of the University of Nebraska websites was very kind of simple and easy to understand why it's important to wear masks. If both the person who has COVID-19, who may be asymptomatic or symptomatic, and the healthy person wears it, and you're in contact with each other, then you're at low risk of acquiring. However, if either one of you is not wearing a mask, then the risk is medium, and the highest risk when neither of you are wearing a mask. The same graph from before, from last time, on social distancing and how you can alleviate stress. And just a reminder on firework safety for today.
Okay, thanks so much. Perfect. Thank you so much, Dr. Padier. I would like to start from your end. So speaking about mask, there is some confusing, I think it's rumors about the negative impact on children wearing mask, like induced acidosis, hypoxia, stuff like that. Is that true?
No, I think, Dr. Alsmari, you wear masks when you're in the ORs for hours and hours, right? When you're working as providers, we have worked, and especially the surgeons are not just now, but even when they have like hours and hours of surgery, they do just fine. I've kind of gone on to, there are some really good, I like. Med Twitter. So Twitter for medicine is a way to dispel myths, because I find a number of videos where people, healthcare providers wearing masks and everything, and then they're actually showing you the oxygen stats, the carbon dioxide levels in your blood, based on the finger monitors, hours after wearing that, being completely normal. So yes, we do not want children younger than 2 years definitely to be wearing face coverings, because because of the risk of strangulation, choking, if they don't use it properly. But if the child is able to handle it, that's okay. Again, if that child is constantly going to be touching their face and mouth, and touching the mask, putting it here and there, sharing with other kids, then that's probably not a good idea. So I think it's children are going to, it's going to be at least a norm for the next few months. So maybe now is a time at home to start getting them prepared, because when they go back into school, we want them to use them responsibly. I'm not worried about any of the side effects or any of that, any of those misconceptions.
Gotcha. So I invite everyone to type questions in the chat box or raise your hand to unmute you to ask questions verbally. I wrote down the questions that you have questioned in the box, and also I wrote down my inputs about the presentation. So I will start from the questions that I received in the chat. One of the audience asked if my son has severe allergies, like seasonal food allergies, is he or she considered like a high-risk individual to consider about going back to school?
No, allergies are not considered high risk for getting COVID. Although what may be tricky is come, fall, start of school, when they have allergy symptoms, then how is the school going to be able to differentiate from the other? But so having a clear idea of how your child behaves, that's more like what symptoms they have is very important. And I'm hoping that that all that level of clarity will be more evident come before school openings. So schools I'm hoping that they will have some more clarity on how they would handle children with allergies, because we don't want them to be missing out on school.
So when you say that we hope things will be clearer as school start, are you as infectious disease specialist involved in policy making the state of Missouri or the school system?
Yeah, so not myself specifically. So there were one of my mentor from St. Louis Children's was involved, and just yesterday recently they shared with us the algorithm that they came up with. So in a way, yes, but I'm personally, I was not instrumental in taking it off, but yes, they are open to getting feedback from all the pediatric ID doctors in the state, so that they can feed in that information to the Missouri DESE. Actually, there was a very nice webinar on that's available. I'll send you a link to that as well. It's a between the superintendent of schools. I don't know what
Yeah,
the of
superintendent.
uh, Missouri schools, and one Dr. Orshlin from St. Louis Children's, who was sharing data as to, and there will be more updates. So I would keep an eye out. This is just June. Schools are yet to start. Sorry, this is just July, early July. We still have a month and a half before school starts. So I would expect some more clarity and coming from the school districts.
The other question is, do we are we having any more idea about where kids get the infection from? What are the main resources where they get infected?
Yeah, I think it's predominantly from the adults in the household. That's been kind of the consistent theme, is that rather than the child being the index first case, it's usually they get it from an adult. And so that, don't forget, the Bubbles website has all the evidence listed out there. There are some studies out there on secondary attack rates and everything. There was this recent study from, I think it was from, I can't remember if it was from France or Australia, where they showed this, even though there were there were cases, children detected in schools, the secondary attack rates were much lower relatively. So
What do you mean secondary attack rates?
secondary attack rates means if a child gets an infection, how good are they at passing that infection on to another person?
I see. Not to adults.
It could be to adults too.
Uh-huh. And can that be happening from asymptomatic carrier children to adults
I
household?
don't think we know that much detail about asymptomatic. I think we are just kind of figuring things out. So,
Okay. So that would take me to a question about contact tracing. I will share my screen just quickly to show you a website that came up from, I think, a collaborative effort between Georgetown University and Stanford University. And this is the link for the AAP recommendation. I just put it in the chat box so you can see the COVID-19 recommendation by the American Academy of Pediatrics. My question about this website, it's called COVID Act Now. And
yes.
that compares basically the risk in each state. So it's interestingly to me enough. Can you see it now?
Yep. Yep.
Yeah. So Missouri is highlighted red compared even to Texas. And when you click on that, it shows you that Missouri is not doing great job in terms of contact tracing. It is the critically high in terms of contact tracing. So put us in the ideal contact tracing effort. What does that mean? How it looks like, and how that impacts the risk of the state as a whole to go through this pandemic.
So I cannot comment on why we are not, why our contact tracing is not very good. It looks like that's the reason why the state got the red color compared to the other states. So, but if we were to able to identify every contact of a person who had COVID-19, then you're able to break that cycle. If you're able to identify those people, put them in quarantine. Quarantine would be the word, and take them out of the community, then there are less chances of spreading to other people. So I still think that the R naught for I don't know what the R naught, so that's how many people can be infected by one person who has COVID-19. That's still kind of in that fluctuating range between 2 and 2.5. But if you take that person out of the out of that community, then you're eliminating the risk of that person passing on to 2 or 2.5 more people. So I think it's very important for that reasons that contact tracing has to be pretty effective, has to be pretty solid to be able to decrease the number of cases. I think Boone County is also, like, just yesterday, on the last couple of days, they put out alerts on people who had visited a certain pub in town, a couple places, I think, where they may have been exposed. So I think I would recommend everyone stay in tune with our Boone County health alerts. So you can recognize if you've been to a certain place, then you're at risk.
I see. All right. The question about race discrepancy and how it affects people unequally. So we know in the midst of social justice rise and calls about racial equality and justice for the entire community. But why is that happening? Is it due to some genetics problem in some races? Like we know that like sickle cell anemia runs in African American. Is that the high incidence of underlying conditions among certain races can put them under higher risk of impact
Right.
with COVID-19?
Yes.
Or
So
there
that's
is
what we have
flaws
seen.
in our health system that puts certain people under higher risk of being affected?
I think it's a combination of factors, but one of the main things is, yes, being a Black American makes you vulnerable to all, you're already vulnerable to everything, to inequalities in the community. And on top of that, so there are more underlying conditions. Access to healthcare is a problem as well. And so I see it as a combination of things.
I see. And just like a quick comment on this, the vast majority of like Muslim community are either immigrants from like Middle East or North Africa, and we are basically not represented in any of these categories. We're not Africans, we are not white, we are not Asians, right? So that's put an important task on us to press our representatives to add the MENA, the Middle Eastern, North African, minority or like race and classifications that at least will show us as numbers in all the data and clinical information and every other aspects.
Yes, I agree, and that was something that was brought up in one of the, we in MU system we had one of this diversity and inclusion kind of talks and seminars for all of us. That was kind of one of the things that was brought up, was having more granularity in the societal data so that we know what to expect. It's likely that since we're to be able to come into the US and work here, we have to have certain educational background, or should be able to I see our group of people as being having probably more easier access to health because we are a select group coming here,
Yeah.
but
Right.
we don't know.
I see. From general information that I can conclude from the graphs that you put, that typically we are dividing the pediatric age group between 0 to 9 and 10 to 15. And it seems that the older the kids, the higher the risk compared to the younger ones. If I have two kids, one in middle school or high school and one in elementary school, should I be more cautious about the older one, not the younger one?
Yes, probably so, because they're going to be more engaged in the community, like being
Contact.
more socially active relative to your younger kids. But I would be more worried about the adults passing things on. So trying to, rather than protect them from each other, keep them together, but limit contact with others from outside the family, outside your close social circle.
So if like small, like if like small group of families get gathered together, like three families, and the kids play aside, will that be a risky behavior to them,
I
or
think
does
it would
it
be
matter?
okay, but again, depends on how well you know the families and how well you can, So I think it all comes down to a personal choice by
Yeah,
that time.
I see.
How responsible you think your friend circle and family circle is to keep themselves also limited. So I think it would be okay for kids, but I think we're still, I don't know. I mean, this whole thing has been such a roller coaster that, we opened everything, cases went up. People thought that come summer things will get better, but they didn't. They actually are getting worse. Um,
So that's interesting thing. We actually, when we see numbers going up after reopening, shouldn't we expect that we may think about reopening and like another way? Should we reclose and think about how to slow down the curve, or we just keep things going and looking at the curve going up?
There's so many other factors that play into, there's all the economic and business,
Politics.
everything that plays into this, that unfortunately we are in, not in a position to make those decisions. But
Exactly.
at least I think, expecting people to be more socially responsible. I am seeing when I go out, going like uh, out to grocery stores, people wearing masks. But at some point, I know Texas yesterday, they announced that masks are now, correct me if I'm wrong, that everyone has to be wearing masks out in the community.
In Kansas City and Texas, in Colombia, the mayor is like trying to push toward the similar policy, but it's hard. Like the mayor of Kansas received a death threat because of the public mask policy. Anyways, have we learned anything from the daycares that remained open during this lockdown period? We know many working individuals kept their kids in daycares, and I see many patients of myself come to my clinic, and when I talk to the parents, they have their kids going to daycare and never stopped. Did we learn anything from them? Is there any outbreaks through daycares?
I haven't heard from our health department of any outbreaks as such. There may have been exposures, etc., but not in the out to the extent that they were called as outbreaks or what they call as super spreader events. So, I do hear sometimes from providers saying they had more than one child in a certain daycare, but that never ends up being kind of an alert from the health department. So I'm assuming that once they take out those children from that community, from that group, the rest do fine.
Should they quarantine the other kids or close the entire daycare after that if the one kid tests positive?
I think it depends on the amount of contact. So I would totally rely on what the health department recommends for that group, because there are so many moving factors, like what are the age group of the kids, how much contact they've been in with each other, how many adults taking care, what was the adult child ratio, etc. So I think it's hard to make like a specific like a general recommendation for all daycares. It has to be really specific to that particular environment.
And does the healthcare available? Is it available for like personal contact? If like let's say my son's private school has a suspected case or a positive case, can they reach directly to the health department, or should they?
Yes, yes. So if there is a positive case, the health department will be involved in contact tracing and kind of directing kind of the cases that are positive. They will be telling them when they can come out of isolation. Those phone calls are made, etc. So I recently our Boone County Health Department has a very nice Facebook Live sessions that happen. I had talked on one of those sessions over a month ago, just like 15-20 minutes, but every week they have somebody kind of speaking up there. One of the recent talks was where people are being reassigned to being so there was like a clinical educator for the health department who was reassigned to becoming a contact tracer. So they're getting, they're recruiting people from different roles to fill in that contact tracing component.
Nice. If a kid lives with a household that includes elders with underlying conditions, like let's say grandparents with diabetes or hypertension, um, should that high-risk individual be worried about the kid become asymptomatic carrier for him or her? Should we rethink about sending the kids to school to prevent this, or there is no enough data about the kids to adults transmission?
Yes. So I don't know if that should be a reason to take away a child's education.
Yeah,
Um, I think the better thing to do there would be to keep the elder person in the household either isolated from them or limiting their contact. It is a very hard decision. It's very hard. Or keeping that bubble really small of people they are in contact with. I would be less worried about kids bringing things home more than I would be more concerned about kids taking things from home to school.
yeah.
Um, Yeah,
Okay.
it is very, very tricky. There are so many unanswered questions in this school reopening. But if I think, some people say that instead of opening up, let's say bars and other places. Now, I have nothing against them, but 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 maybe we should limit all those activities and allow kids to go to school instead. So, prioritize them over other things. But that's my
Um,
personal opinion.
sure. I think I understood. Correct me if I'm wrong. So basically, we even like, let's assume the kid get positive COVID-19 through his classroom or his class.
Mhm.
As long as there is no mass contact with other kids in different classes, the only small bubble at risk is his or her classroom that need to be traced or isolated.
Yes,
But if
yes.
the kid get mixed with other classes, like in a lunch break or in a recession or in the cafeteria or PE classes, this should be modified in a way to limit the bubbles to the minimum so that any single case will not harm the entire school, just like the single class, right?
Right. Absolutely.
Cool.
And, you know, if if this was not like it will literally essentially then shut down the whole school if that were the case.
Exactly.
We don't want that to happen.
All right. Speaking about high risk individuals, if a kid has persistent mild asthma,
Mhm.
is that high risk?
So far the what people are thinking is usually just moderate and severe asthma.
They are high risk.
Yeah.
Okay. Now, this is going to be mostly like a hypothetical question, but bear with me
Mhm.
and answer as much as you can. So let's say my son, who is in third grade, wake up in the morning, not feeling super good, not bad, just like the classic laziness of early morning wake up. Went to the school, and the school was good. They scanned him and they found high temperature. He has no symptoms beside the mild fever detected by the school. The expected scenario that I will take him to his pediatrician and they probably will test him for COVID. Is that what's going to happen for every kid who sent back from school?
It's a likely. Again, that's the kind of details that everyone wants to happen. So that's the kind
That's why
of.
I want to imitate this scenario so we can have some insights.
Yeah.
So,
So I would say that if the child has a fever and they went to see the pediatrician, of course they're going to do a full check. So in case they find that your son has a ear infection, or if they find that they have a strep throat, then easy enough, they would treat that accordingly and then follow the guidance for that. So for strep throat, being on antibiotics for 24 hours before you can go back in. And of course, fever should have gone and you should be feeling slightly better and on the mend before you can go back in. So not every child who has a fever is going to need a COVID-19 test.
so this is excellent start. So because currently, since we cannot distinguish between other respiratory symptoms versus COVID, we are considering everyone who has mild symptoms to be COVID unless proven otherwise. And even if a patient don't come and test, treat yourself at home and contact us if you get worsened. Is that going to change for kids? Because basically every kid will get sick, for the fall disease that you just mentioned. So we are not going to consider every single sick kid as a COVID. Is that correct?
That's right, and that will have depend really on the doctor who's going to check the child. But I think it's possible that they may want, even if they find another reason, they may want to do a COVID test. Depends on how easily they're available. We've been lucky in our city to have easy access to testing, free access to testing through the hospital, through the drive-throughs. But that may not be the case for smaller rural communities to happen, where if it looks like, if and again, if there is nobody else sick in the household, the chances that your child has COVID-19 are much lower.
Let's say, like an anxious parent like me, okay, I want insist to get the test done to make sure that my son is not positive. We went through drive-through. They took the nasal swab, right?
Mhm.
They did the test. How long it takes to get the result?
So we are with the drive-through, we are seeing up to 24 hours turnaround.
Mhm.
And that is really great. We've been so lucky to have such great turnaround. And if you're in the ER, or if there is you're in the ER, and the provider decides to test you, or you're sick enough to need hospitalization, we have in-house testing, which is even faster. Within a few hours, we have the results.
Perfect.
back. So,
Okay.
but I would say that if your child is sick and they've been sent home, you're not going to be able to go back to school the same day. You're going to have to
Actually, yeah.
either take them to the doctor, have them examined, whether
Yes.
they get the test or not. It's still going to be another day or two.
Okay, so let's divide the probability to. So test came back negative.
Mhm.
Does that mean he's cured, he's okay to go back to school, or it could be false negative?
Now that's the other concern as well. So if again there was another reason that you could attribute it to, that would be good. But if with limited, if they don't have fever, cough, shortness of breath,
Hmm.
and those are the predominant symptoms, then the chances are very unlikely that they still have that with a negative test you have COVID.
Yeah. But I mean, we heard a lot about like barely symptomatic or really asymptomatic kids, right?
Mhm. Yeah, and so that's where it makes sense then to continue all the social distancing in the
Exactly.
school and have masks for children who can safely wear them,
Okay.
because on the small chance that they are asymptomatic or mildly symptomatic or they have a false negative, you're still protecting people.
So test negative, next day he feels well, no fever, no symptoms. Like for 8 hours passed, he is okay to go back to school. There is no need to repeat the test again.
No, there shouldn't be a need to repeat as long as your child is starting to feel better.
Okay.
So if they're getting better and they're no longer having fever, no all those symptoms are improving with a negative test, I would expect that now. I think schools may require. I don't know if they will require a note. I mean, they usually do require a note, but with colds and all of that, schools didn't used to require a note for return to school from the
Mhm.
doctor. So it's possible that they may put in some more um, like specific recommendations on that as well.
Okay, let's say, God forbid, the test came back positive. So now the school should contact the health department, right? And
Yeah.
they whoever
So
replace all the individuals that contact my son for 8 hours beforehand.
yeah. So for the 2 days before, so currently we are based on the information that we have, they contact trace going back 2 days
Two
for the
days.
first symptom, and um, even I'm sure the school will notify as well. But the notification also goes from the lab to the health department. Um, and so then they will kind of reach out and all of that. So I don't know, since I don't know what um, communications have happened between health department and our school district on these details, how things will work through. I'm not aware of.
A, a, a quick like subdivision question here. So from HIPAA standpoint and patient privacy standpoint, is the school allowed to announce that the student name such and such test is positive, or they just have to announce that there is a student in our class who tests positive, please self quarantine for next week or so?
Yeah, I think it might be the latter where unfortunately it may not be very hard for people to figure out.
Yeah. All right. So I think the next question will be if the child is at home, test positive with very mild symptoms, and we basically treat those kids at home, what would be your recommendation for treatment policy
I think
for mild cases?
if they're not sick enough to be in the hospital
Yeah.
or to be admitted to the hospital, just symptomatic care. So making sure they're hydrated,
Mm.
can treat their fevers. Of course, some warning signs if they're feeling very short of breath, wheezing a lot, things that you would think about taking to the doctor. You shouldn't hesitate or delay. The other message that came out when we all clinics and everything were scaled down, the numbers were really small, people were limiting access to care. um, the the message came out that hospitals are also not safe. But now, we want families to feel comfortable taking your child to the doctor to be examined, even in doctors' clinics. At least I know in our system, like at both the hospital and the clinics, they have their visiting areas separated between sick and well kids. Even the seating space, seating in the visiting areas is separated out. Everyone is expected to wear masks coming in, including parents. So it is a safe place. Do not hesitate to go do not delay. What we also saw was, I can think of a few cases where a child who ended up having something different, like what I often get involved with managing bone joint infections as a part of my regular infectious disease care, where we it was pretty obvious that they wanted to come, but they didn't come because they were afraid to come to the hospital, or they thought it was something else, or they were asked to get a COVID test by somebody and only then they could be seen, etc. So please, we don't want you to delay coming to the hospital, because it is a safe place to be in,
Yeah.
probably safer than anywhere in the community.
Nice. So speaking about parents, so let's say my son, God forbid, get positive and he's treated at home for mild COVID-19. Should I be worried about spreading the virus to my patient? Should I also quarantine, cancel my clinic for 2 weeks? Or again, because the kid's adult transmission rate is not none, I shouldn't be that worried.
Yeah, that is a tricky one, right? For something that us as healthcare providers are always very anxious about. And I think in that scenario, you would be considered as an exposure. And so it would, as I think logically, it would make sense that you would also have to be in quarantine for that period of time. But it has so many ripple effects and downstream effects, because if you're not there, who's going to be taking care of pediatric children coming to the eye clinic?
Yeah. It's tricky.
I didn't know if I and
You need to
the
go?
people remaining on the call, I only recognize Dr. Khalil. I don't know if she's still there, if she had any thoughts, as a primary care doctor, as a doctor in newborn nursery as well.
Yeah.
He
I
has
was
a-
about to call on her as well. I just wanted to conclude with you about this question. But Dr. Khalil, if you feel comfortable, can unmute yourself and add some comments about how you are expecting to handle COVID-19 kids, and especially like your kids go to the same school as mine. So we are in the same stress process and thinking how to send them back to school. So if you feel comfortable, you can unmute yourself and tell us about your experience with COVID-19 so far. Okay, let me unmute you. Sorry, I need to maybe not Khalil. Yeah, you're welcome.
Okay. Good morning. Thank you so much for talking to us. Very informative speech. So yes, I've had a lot of the same concerns. I do feel like Dr. El-Samar, you were asking a lot about testing. I'd probably be one of those that would be a little bit more cautious and end up testing just to make sure. But thankfully we haven't seen too many. I haven't seen many positive cases, but in the last month, I have seen more parents that have been positive. So I know some of my partners have seen those positive parents, their children have been positive as well. So definitely before, when I felt like we haven't seen, it hasn't touched many of our patients, now it is for sure. And some of the exposures that we're getting in the hospital a little bit more now as well. So I think we just all do need to be very cautious. And I think one of the blessings I feel like for us is that our school is a little bit smaller. So hopefully we may not get as many exposures, but I do think we have to do a good job of creating those bubbles and limiting interactions between the classes, and hopefully keeping limited adult exposure as well. I feel like some of the daycares and talking to patients, a lot of them have been really cautious. They don't let parents inside the building. They test the kids. The teachers get tested, meaning like fever checks and like symptom checks. So I think that has been part of the benefit of some of the daycares not spreading. And I think there was one like end of May, early June, where on the news they were talking about a few cases, but I think it was a caregiver that was positive, and then some of the children were positive. So I do think we as adults need to be very cautious. Seems like the kids are getting it from us. So yeah, we haven't seen too many yet. So we'll see what it'll look like in the fall when we have lots of other viral infections and everything. So there you go. Little Sinan is on the on the Zoom too.
Yep.
learning with all of us. But yeah, I think, like you said, I'm hoping as we get more information, as we get closer, I think that'll be helpful. I know mask, I'm a little bit concerned about how well the mask will go. I just know in clinic with patients, they're constantly taking them off. And, you know, once we're in the room and it's limited, I always keep my mask on. So if the kids can't tolerate wearing their masks, I just leave them. But yeah.
I do insist on the parents though wearing the mask.
Yes,
Although
and the
sometimes
parents have them.
also want to take it off, but that's not an okay.
Yeah, that's true. Yeah. Well, thank you very much. I don't know if there's anything else you guys had for me, but I appreciate you giving us all those updates. It's helpful to see. And it'll be helpful as you guys continue to work with the state, what new plans or recommendations you give us.
Yeah, I hope so too. And hopefully there will be enough clarity for both schools and providers as well.
Yeah.
I saw maybe like a couple of pictures from China. They create this like transparent plastic partitions between desks to compensate for the mask restrictions and difficulty with kids. So the same that we see like with cashiers and, you know, PSRs in our clinic, they have this plastic partitions between desks to limit exposure somehow. Do you think that's also effective?
I mean, any kind of barrier is okay, but I don't know how it'll be easy to pull that off in our schools where desks are always moving around and all of that. Face shields have been brought up, but the question about face shields is, will they, hopefully the kids are not going to be swapping face shields. And how well will they be cleaning them after use? So they come home, they're clean, and then go back to school, you know, with clean face shields. So I've heard of some schools, not in our state, outside in one of the webinars with providers from other states. They had mentioned that some schools are going to use face shields instead of masks, which is really good, as long as, just like masks, if they are effectively used, then that would be great. It would at least keep them from touching that mask and adjusting their face all the time.
Anyways.
Like even as adults, I see many people like take their mask off and put it on the table. I mean, then it's not going to work.
All right. I think we covered everything. Thank you so much, Dr. Fadia, for your beautiful information and very generous, you know, time and business. And thank you for, you know, enlightening our community again on these important updates. And I hope this information will help us making decisions whether to consider like online schooling versus physical schooling. And I pray that everyone stays safe and healthy, and may God protect us all and our kids until this pandemic will be over and part of history, probably soon. Thank you so much again for everyone, and enjoy your holidays, and happy 4th of July.
Thank you. Bye.
Thank you so much. Bye-bye.